Hi, thank you so much. Thank you to the organizers of the conference. Thanks for inviting me to talk today. It's not enylbutyrate, it's phenylbutyrate, but somewhere from Mac to PC we lost the PH, but I promise it's there. I'm Zach Grinspan. I am the Vice Chair of Health Data Science, and I direct pediatric epilepsy research at Weill Cornell Medicine. And I'll be talking about phenylbutyrate for monogenetic developmental and epileptic encephalopathies. And with this audience, I'll be focusing on Syngap. These are my disclosures. And I have to give a shout out to the families, to parents of children with Syngap and other DEEs who have very successfully raised tons of money to help support research. That's how this whole thing got started. It was from the Orphan Disease Center, which is at CHOP, SLC6A1 Connect, which is a family-led, STXBP1 disorders, Clara-inspired. That funding got us going. We then showed some good results with Ravicti, the drug I'll be talking about, and then Horizon very generously provided us with some drug to do the study. Horizon has since been bought by Amgen, and Amgen provided us both with drug and some funding, some dollars to help get this going. So, and then I would be remiss not to give a huge shout out to Children's Hospital of Colorado. Scott Demarest in particular has been a real thought partner, an actual partner in getting this work done. I think I just said what is on this slide. This is our team. We have this really stellar team at Cornell, and I've gotten to work with the Children's Hospital of Colorado folks who are also outstanding. So what is this drug? Phenylbutyrate. It is an FDA-approved drug for something else. It's a drug for urea cycle disorders. It helps get rid of serum ammonia. It crosses the blood-brain barrier, and it comes in two flavors. There's a disgusting flavor, the sodium phenylbutyrate. This is salty, it's bitter, kids can't tolerate it. And then there's glycerol phenylbutyrate. This was essentially created as a molecule because of the poor tolerability of sodium phenylbutyrate. It's the same thing. The glycerol phenylbutyrate, those 4 phenylbutyrate molecules pop off in the gut. Why did we select to try this drug? There's a bunch of preclinical literature, interestingly not in Syngap, but in several other diseases, that suggested this would help with genes associated with DEE. And so it's an interesting group of disorders. STXBP1 is involved in releasing vesicle contents into the synapse. SLC6A1, they're next door with their conference, is GAT1. It's a GABA reuptake channel. GABA A receptors, this is involved, it's sort of like an inhibitory listener in the central nervous system. LGI1, this group is not in our study, but we're interested in them. LGI1 is involved in sort of connecting the pre- and post-synaptic membranes. SLC6A8 is creatine transporter disorder, but it also may have some involvement in the synapse. SYNGAP1, you all know and well, and then SCN1A is the gene associated with Dravet syndrome. So what do all of these genes have in common? Well, they're all associated with epilepsy and seizures. They all seem to impact synaptic function one way or another, and all of them, except for creatine transporter disorder, all of them are haploinsufficient. So you've got one good copy and one bad copy. Millie Stone is a research coordinator who's been working with me. She's just about the smartest person I've ever worked with. So if any of you are on medical school admissions committees, please select this young woman. She's brilliant. Millie put together a review of everything we know about this drug. There are a number of cellular mechanisms that have been hypothesized to explain why it might work, and then they all kind of condense on a couple of functional impacts. This is a list of all the ideas that are out there, and every one of them has a strong argument in favor. My current thinking is that the argument that's at least making the most sense to me is that phenylbutyrate is working as a positive allosteric modulator for GAT1. The group that has been the most respondingest, if that's a word, is the SLC6A1 group, and that's GAT1. That's the mutation in GAT1. But all these other ones are very real and may be contributing, so it's not clear what the actual cellular mechanism is. The functional impact is going to be one of four things. Either it's enhancing that wild type and it's making the wild type better, or that mutant that's not working, maybe it makes that one work better. Maybe the mutant is toxic and affecting the wild type, and so somehow phenylbutyrate is protecting the cell against the mutant. Or maybe it's something else. Maybe it's some other anti-seizure effect that remains cryptogenic. We were convinced enough to start a trial, and so we launched a study. It's ourselves at Cornell in New York and Children's Hospital of Colorado. It's an open-label, multi-dose, single treatment group study. That what we did is we did a screening call, and then we would roll people. We'd do 4 to 6 weeks of baseline assessment to understand folks' seizure frequency. We would bring them in either to Cornell or to Colorado for 3 days and 2 nights to get EEG data, start the drug then. Early on in the trial, we just did 6 weeks, and then more recently we moved to 12 to be more aligned with traditional anti-seizure medicine trials. Then they would come back for 1 night in the hospital, and then we would do some follow-up. They could then stop the drug if they wanted to. Most of the people in the trial decided to stay on the drug, and Amgen has generously given us extended use. So it sounds like there's been some confusion. If you are in the study, you still have access through December 2026, regardless of which arm that's available. What we're essentially doing for 2026 is trying to transition people to commercial supply. But it's hard because the drug costs $800,000 a year. The results have been really nice. We published our initial findings with STXBP1 and SLC6A1. That's in a preprint. Safety and tolerability. There really have been no novel adverse effects. So there have been adverse effects. People have been hospitalized. We've had SAEs, but nothing new. So as I've learned about clinical trials, the important thing here is that we didn't see anything that the FDA didn't already know about from their approval process. There's a sweet odor a lot of kids get. They get sleepy. They can get appetite suppressant. That's all tolerable. The metabolic acidosis is the thing that's gotten us into trouble. Kids have gotten sick. They stop eating. They've ended up in the hospital. We've had some patients who the acidosis has been quite refractory, and we've had to either cut the drug in half or stop entirely to get the pH balance back together. But the FDA knew about that, so we were okay. It's been well tolerated. We haven't seen a lot of missed doses. We enrolled 50 kids. 37 of them are continuing on the medicine. 10 of them stopped because it didn't work for them. 2 of them stopped both because it wasn't working and they had side effects. And then 1, it was working, but the child wanted to enroll into a different trial, and so they came off. I want to think particularly today, and I seated a couple of folks that came in to think about development. So I'll show you the seizure outcomes, but I want to think about development and how do we quantify that in these small studies. I have some ideas of how to do that. The way I think about development for the developmental and epileptic encephalopathies is in this space where you've got chronologic age on the x-axis and age equivalent on the y-axis. So if you're a neurotypical child, you are on the diagonal. As you get older, the age equivalent score, more or less, on these developmental assessments should grow with you, right? And there's going to be variation. Maybe you're a little low, maybe you're a little high, but you should see this linear growth. In most of the developmental and epileptic encephalopathies, kids start behind and they fall further behind as they age. Their development plateaus. And so, a kid who by 10, for example, isn't walking or talking, you don't expect them to be walking and talking by 12. Their development plateaus. And so as we think about therapies, particularly early, right, as these new ASOs, AAVs, and we don't know how good they're going to be, and we're giving them to kids who've already had symptoms for several years, or we have repurposed drugs that may have been targeted for something else, and maybe there's a marginal benefit. Our hope is not that we're going to get people necessarily to the green, although we would love that. We just want to make sure kids get better. And so the ideal is really like a blue trajectory here, that their trajectory starts to return towards normal, even if they don't actually get there, but they're better than they would have been. So keep this in mind as we sort of think about the actual data. The actual data is messy, but I will show it to you. I was a math major in college, and it was nice to return to some math in thinking about how to do this plateau. We need to model this developmental plateau. And so I wrote an equation down. This is an exponential decay equation. And the innovation here is that the parameter in the front, that's like your multiplier, is the same parameter as in the exponential. So that k appears twice. What's nice about that is you only need a single point to fit this curve. So you can get someone's baseline, and then you can predict where they're going to go. That k is also nice because it has meaning. The k is the age equivalent at which they plateau. So if a child is going to plateau at the age equivalent of 2, then the k is 2 years or 24 months, depending on how you're doing the math. I have the same slide deck for all the diseases. Hang on. SYNGAP. So here, these are the seizure outcomes. This is still preliminary, and my apologies, I should have maybe done this in 2 slides to make it clear. We enrolled 9 children with SYNGAP. 3 of them are clearly responding, and that's the clinician in me, not the scientist. They went from that top row, 1 to 3 per day, to maybe 1 or 2 per week. And then when I last saw that child, seizure-free for 6 months. Another one went from multiple seizures to day to 4 weeks of seizure freedom during that 12-week period. Those seizures have come back, but they're less intense. And then the third one went from 5 to 10 per day to 7 in 12 weeks. At the 1-year point, that child had been seizure-free since the second admission, and at the last visit, there was 1 breakthrough seizure in about a year and a half. So those are clear clinical wins for me as a clinician. Like as a scientist, I'm like, well, what's the p-value on that? It's the end is sort of small. The other interesting thing about those kids is that we've been able to reduce some of the medication burden. So they're taking fewer other anti-seizure medicines. They haven't weaned off them entirely, but they're still taking them. They're taking the goal dose, more or less, of what we wanted them to take. And remarkably, 2 of their, or actually all 3 of them, their EEGs are getting better. All 3 of the kids in that top row had seizures during that first admission. None of them had seizures in the second admission. And by the 1 year, 2 of them no longer even had epileptiform discharges. I don't know if this is natural history or if this is the drug, but it's certainly encouraging, intriguing, and promising. The next 3, I went back and forth on. There are some things about them that were positive, some things that were about them are negative. I still need to run through the seizure diaries in detail. And then there's 3 that did not respond, where the before and after were about the same. If there was an effect, it was transient, not convincing. Interestingly, of those 3, 1 withdrew and stopped taking it, but the other 2 have stayed on the drug. 1 at the goal dose and 1 at a slightly lower dose. So we're encouraged by this. This is not a cure-all. It's not going to be for everyone. But for refractory developmental and epileptic encephalopathy, any tool that we can provide, both to ourselves as clinicians and to the rest of the clinicians in the audience and in the community, is going to help some of the kids. So we're happy that that we had some wins. Let me move now to development, and this is where the data gets very messy. There's no good current detailed natural history study. They're ongoing, but the data's not out there. So I was able to get a hold of Simon Searchlight data, and then RareX has been collecting some data. And I plotted those data in this chronological age versus age equivalent. The darker grays with the lines are patients that have serial measurements, so you can see their trajectories. And then the other dots are kids that only have a single measurement. And then I just fit those decay curves and put them as percentiles. On the right, you can see like a box plot of what those K values are, and it suggests that kids max out, somewhere between 3 and 4 years old, age equivalent on these 4 measures. I was chatting with Jillian. The interesting thing is, do I have a pointer? Let's see. Yes. In all the graphs, there's a bunch of dots, and it's both Simons and Rarex that are very low functioning and only have a single measurement. And so my percentiles are almost certainly wrong because we're not picking up those lower functioning kids. They probably all just came once and then for whatever reason didn't come again. And so as these natural history studies play out, particularly knowing those low functioning kids and how they do, I think is going to be really interesting. So this is the data we collected. It's both blurry and it was messy before it was blurry, so bear with me. What I did is I said, all right, let's just plot this out so we can see. It's 4 domains, receptive, expressive, gross, and fine. I used Bailey and Vineland from our Ravicti study and then plotted them out and then just kind of fitted a line to them. Then for each of those lines, I just put the line as well as what the plateau trajectory would have looked like. Those are those thin gray lines. And then those thicker line segments, the ones that are blue are the ones that were at least 3 months better than you might have expected. So if on their curve they were supposed to be 4 years age equivalent and they bumped up to 4 years and 3 months, I colored them blue. And then there's actually, hold on. No, this is right. So there's 2 that got better with receptive, 1 expressive, 1 with gross motor. So we didn't see, on the whole, too much improvement on development. What I don't understand, whether is this real or is it noise, is that a lot of kids got better on fine motor scores. There's 1, 2, 3, 4, 5 of the 9 that we treated had these substantial benefits with fine motor. So this was unexpected because the families hadn't been describing that to me. And so I'm mentioning it to you as sort of an interesting observation for us to think about as both for natural history, like is this something that kind of pops up out of the blue in kids? Is this just part of their natural history? You start paying attention and their fine motor gets better? Or is this a real effect that we should take seriously and then maybe consider for clinical trial outcomes as some of these ASOs and AAVs and other repurposed medicines come to bear? Limitations, small sample size. It's an open label study. Seizures are hard to count, so tonic seizures happen at night. Kids have absence, blinking cells, head drops. Those are difficult to count. I don't really know the natural history. I made an educated guess just so we could kind of think together. Next steps. So there is many voices are very enthusiastic for me to publish these seizure outcomes, and I'm listening to those voices. So we'll get a seizure outcome manuscript that'll have SYNGAP, GABA-A, STXBP1, SLC6A1, and a handful of other diseases. The non-seizure outcomes will come next, including the developmental outcomes. We're thinking about EEG biomarker. There's a really robust one that we're working on for SLC6A1, and my thought is like once we get it settled for them, then I'll move it then to SYNGAP and see how it does. And then of importance for those in the trial, many would like to continue the Ravicti. It's very expensive and insurance often balks. Insurance has paid for some kids, but not for everybody. So with this 1 year of kind of bonus time on the study, we're essentially using that as an opportunity to transition kids to commercial supply. Once we publish, actually, we've already started these conversations. There are 4 or 5 of these organizations called compendia, and they list both on and off-label indications for different drugs. The cancer community loves this because there's federal legislation that says if it's off-label but listed, you have to pay for it. So we're going to try to piggyback on that and try to get this listed as an off-label use. I've submitted those requests, and then somebody else asked me who to email, and so I think they're going to get a little bit bombarded with some requests. So that's how we're going to try to get this into people's hands to use it. And I'll stop there. Thank you.